Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 455 of our pharmacotherapy series, which majors in pediatric malignancies. The next case reads, BSN is a 34-month-old boy who is pale and irritable. He has had abdominal complaints with decreased bowel movements and reduced oral intake for 2 weeks. He has played less than normal for the last 4 weeks. BSN's blood pressure has intermittently been as high as 146 systolic, 87 diastolic. The normal, 90th percentile, is 106 systolic, 69 diastolic. His laboratory results include the following: a hemoglobin of 7.9 grams per deciliter. The normal range is 11.5 to 13.5 grams per deciliter. An erythrocyte sedimentation rate of 139 mm per hour. The normal value is less than 10 mm per hour. BSN has a history of hyperspadias and left hydronephrosis. Scans show a right kidney mass extending through the capsule plus 2 distant metastases in the peritoneum. Chest radiography shows 1 nodule in the lung as well. Pathology from a biopsy sample shows favorable histology Wilms tumor. So my first question to you reads, what treatment should BSN receive? BSN has stage 4 disease with favorable histology and the cells are negative for loss of heterozygosity at 1p and 16q. The expected treatment for him is 24 weeks of vincristine, dactinomycin, and doxorubicin, assuming findings at surgery are consistent with pre-treatment scans. He will receive abdominal radiation. He would also receive pulmonary radiation unless the lung metastases completely disappear with chemotherapy. The series of 5 national Wilms tumor studies have sought to progressively minimize toxicities from radiation and chemotherapy while maintaining the excellent cure rate. The 4th National Wilms Tumor Study Group, abbreviated as NWTS4, study demonstrated that intermittent, higher doses of dactinomycin allowed higher dose intensity with less myelosuppression than lower doses given daily for 5 days. Using greater dose intensity and dose density, 6 months of therapy was shown to be as effective as 15 months of therapy given the traditional way. Also, fewer clinic visits were made and estimated costs were reduced by 50%. The NWTS5 evaluated surgery followed by 18 to 24 weeks of chemotherapy. Chemotherapy was determined by the stage and histology findings. Abdominal radiation therapy was added to chemotherapy for stage 2 disease with unfavorable histology, focal or diffuse anaplasia, or stages 3 or 4 with any histology, pulmonary radiation was added for stage 4 disease if the chest radiograph was positive for metastases. The latter part of the guideline has now changed to depend on whether or not the pulmonary nodules clear with chemotherapy or not. For patients with stage 5, or those with inoperable tumors, surgery could be delayed until neoadjuvant chemotherapy reduces the tumor size. My next question to you reads: are there any special precautions for dosing chemotherapy in BSN? The NWTS2 study noted an excessive number of toxic deaths in infants with good prognosis, and this resulted in a dosing change. After chemotherapy doses were decreased by 50%, severe hematologic toxicity, toxic deaths, and pulmonary and hepatic complications were reduced. Importantly, no decrease in therapeutic effect was noted. Reduction of chemotherapy doses in infants is a consideration for other pediatric cancers as well. Reasons for increased toxicity in infants may include altered pharmacokinetics or organ sensitivity, as well as the larger body surface area per kilogram relative to older children and adults. In NWTS5, dosages of chemotherapy agents for Wilms tumor patients who are less than 30 kilograms were converted from milligrams per meter squared to milligrams per kilogram. By assuming the average 1 meter squared child weighs 30 kilograms, the dose per meter squared can be divided by 30 to arrive at a dose per kilogram, which can be used in dosing calculations. This adjustment lowers the dose by 20% to 50% in children who weigh less than 15 kg. In NWTS5, infants younger than 12 months of age received doses that were further reduced by halving the milligram per kilogram dose. My next question to you reads: are there any dosing precautions required because of potential interactions between BSN's treatments? Another medication-related problem that may arise in BSN is the interaction of dactinomycin and doxorubicin with radiation therapy. Two effects have been reported. One is acute enhancement of radiation effects, and the other is recurrence, that is recall, of radiation effects up to several weeks later, especially to skin and mucous membranes. Because BSN is to receive abdominal and lung irradiation during his chemotherapy treatment, concurrent doses of dactinomycin and doxorubicin will need to be reduced by 50%. And held if wet desquamation of the skin at the radiation site occurs. In many of the Ewing sarcoma and rhabdomyosarcoma protocols, dactinomycin or doxorubicin is stopped during concurrent radiation treatments. The next question reads: when BSN receives lung radiation for his metastases, how will it affect the doxorubicin he is scheduled to receive? Although it is well known that mediastinal radiation can increase the risk of anthracycline-induced cardiac toxicity, the only adjustment for BSN would be a temporary reduction of doxorubicin doses. The total doxorubicin dose should be limited to no more than 5 mg per kilogram, that is, 150 mg per meter squared in larger children. In earlier Wilms tumor studies, the risk of congestive heart failure was 4.4% at 20 years, or up to 17.4% in patients who relapsed and received more doxorubicin. Thus, cardiovascular toxicity can develop as long as 20 years after therapy is completed, with an apparent decrease in left ventricular wall thickness and increased ventricular afterload, probably related to inadequate numbers of myocytes. These reports emphasize the need to minimize chemotherapy in patients with good prognosis, as the Wilms tumor studies are doing. New recommendations include better standardization of cardiac monitoring and continuation of monitoring throughout life in survivors of childhood cancer who receive cardiotoxic agents. BSN is to receive vincristine 0.05 mg per kilogram weekly for 10 weeks, doxorubicin 1.5 mg per kilogram at weeks 3 and 9, 1 mg per kilogram at weeks 15 and 21, and dactinomycin 0.045 mg per kilogram at weeks 0, 6, 12, 18, and 24. During the third week of treatment, his alanine aminotransferase, abbreviated as ALT, is elevated to 78 units per deciliter. So my question to you reads: is this related to his drug therapy? Early in the NWTS4, an increased incidence, that is 14.3%, of severe hepatotoxicity, elevation of alanine aminotransferase or ALT 10 times normal with or without ascites, was reported with the pulse-intensive dactinomycin doses, that is 0.06 mg per kilogram per single dose, in patients receiving no abdominal radiation. Subsequently, dactinomycin doses were reduced. Still, the incidence of hepatotoxicity in patients receiving the newer 0.045 mg per kilogram pulse doses, that is 3.7%, as well as those receiving the standard 0.015 mg per kilogram per day for 5 days, that is 2.8%. remained elevated relative to the NWTS3 results, that is 0.4%, which used the same 0.015 mg per kilogram per day for 5 days. The reasons for the increased hepatotoxicity are not known. Liver function usually returns to baseline within 1 to 2 weeks after discontinuation of chemotherapy, although more severe problems with sinusoidal obstructive syndrome, hepatopathy, and veno-occlusive disease have also been reported. Chemotherapy was restarted in some patients, although frequently at lower doses or without dactinomycin. BSN should be monitored closely in case his liver enzymes continue to rise, especially because he will receive abdominal radiation treatments that may increase the risk of hepatic toxicity. If his ALT rises to 2 to 5 times normal, or his total bilirubin is 3 to 5 mg per deciliter, doses of all 3 of his drugs should be reduced by 50%. If his ALT or bilirubin rises above 2 to 5 times normal, the drugs should be withheld until laboratory values return to lower than the aforementioned ranges. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 456.